This is our REILS Educational Insights and Learning Series, and I am Rachel Patzer. I'm today wearing my, not just my President and CEO hat, I'm wearing my Research Investigator hat, and I'm going to talk to you a little bit about some of the research that my team does and has been working on, and some of the team that I've brought here to the Regenstrief Institute and to Indiana University. I'll talk a little bit about that as well. So I'd say the last 4 months that I've been here, I've been sort of 90% wearing my President and CEO hat. That's kept me very busy, getting to know everyone and learning everything about the organization. But I intend to spend about 1 day a week on the research side of things as I get into the groove of things here. So the research area, some of you may have gone to the talk I gave in December when I was here visiting. I'll have some themes through the talk on some of what I had talked about then too, but I know not everyone attended that, so want to provide a little bit of background about the last 20 years or so of some of the research I've been doing, and really emphasize a lot of the work that my team has been doing and will continue to do. And this is largely in the area of improving equity and access to kidney transplantation. So a few disclosures here. So my objectives are, I want to describe some of the variation and disparities in access to transplant and what motivated the research in this area. I'm going to talk a lot, you might hear some of my research team talking about our RADIANT study, so I'm going to talk about that. There are 4 different iterations of RADIANT. That's the Reducing Disparities in Access to Kidney Transplantation study. So I'll give you a little bit of background on that. And provide some examples of the different areas in which our research team is working on. And then I'm going to talk a little bit about the local context and moving some of this research here to Indiana. So the overall purpose of our research team, this overall goal that we have, is really around improving access to care, equity in care, and quality of care, largely in transplantation. And I would say the focus of my talk today, and I'd say the majority of my research, that we dabble in lots of different areas, but the bigger focus that I want to talk about today is around improving equity and access to kidney transplantation. I could talk for many, many hours about this, but I thought part of what I might do today would be to give you some examples of some of the work that we've done in the past, in highlighting some of the work of some of my team members in different areas. And I'd say largely our team works in the space of data, data collection, quantitative data collection, qualitative data collection, methods, some analytic methods, some epidemiologic methods. Myself, I'm trained as an epidemiologist, so I have my master's and my PhD in epidemiology, but I really consider myself an epidemiologist and a health services researcher, because epidemiologists tend to describe the data, focus on using the data to describe problems, and I see going a bit beyond that in the health services research, doing interventions, advocating for policies, that gets a little bit in the health services research field. So I consider myself both. And we really our research team touches on all of these things. So in the epidemiology, it may be methods, descriptive epidemiology, causal epidemiology. So looking at, what is the association between one thing and another, and can we establish causality there, or is it an association? And then intervention work, so from development of interventions, evaluation, and implementation of interventions. And then I'll talk a little bit about some of the work that we do in policy, whether that's evaluation or advocacy, and trying to establish policies that we think are relevant really to our overall goal of our research program around improving access or equity in kidney transplantation. So, and one more thing I'll say is throughout I've tried to identify some of the areas where our team has played a role in some of the research studies. We are a team-based science enterprise. I think this is really a critical point, that it's never me alone as the researcher and the research investigator. There are just so many hardworking staff and other co-investigators and our analysts and team members, and I'm going to try to acknowledge some of those that have led some of this work throughout. So you'll see their pictures, and I'll try to point out a few people as well, and the role that they've played in this research. So, starting out when I was really a graduate student in what was the problem I wanted to take my toolkit, my methods in epidemiology, and apply that to. It was trying to understand what were the problems that were important to solve. And at the time, I had a mentor who was a nephrologist and an epidemiologist who pointed me to this problem. And you can see in the figure on the left is the geographic distribution of end-stage kidney failure incidence across the United States. And on the right was the geographic distribution of kidney transplant rates. And so I won't give you a ton of background about all this problem other than to say that kidney disease is typically caused by diabetes, hypertension, or obesity. We know that the causes of some of those chronic conditions are actually upstream. Social determinants of health play a major role here, and that is part of the reason why we see geographic differences. This map on the right that really reflects access to care looks similar if you look at other populations of patients and their access to care. But in this instance, the access to care that we were looking at was access to kidney transplantation, which is the optimal treatment for someone whose kidneys are failing. Without a life-saving treatment, those patients will die. So they have the choice of either dialysis or kidney transplantation. And then, interestingly, and what attracted me to this problem, I think, early on was it's a very fascinating policy field, and the ethics are also really interesting. It's an interesting health services research question. But we have, since 1972, dialysis and transplantation are both covered under the Medicare program. So if somebody has a diagnosis of kidney failure, they are able to get a transplant or dialysis that's covered under Medicare. So this is a public program that has been around for a number of decades. And so I was very interested in this problem of why do we see these differences in access to treatment, even when it's covered by health insurance. So, of course, I was living in Georgia at the time, so this was a really relevant problem for our local community that we had among the lowest rates of transplant in the nation. I've pointed out Indiana on this map. Everyone always wants to know, well, where am I here? But this is showing along the x-axis all the states, and then their standardized transplantation ratio, which is the number of observed divided by the number of expected transplants among dialysis facilities. And at the time, Georgia had the lowest rates of kidney transplant in the entire nation. And we know this is actually a more recent paper. I sat on a committee a working group that pulled together, that was held by NIDDK, that really focused on discussing some of the role of structural racism and inequities in contributing to the inequities we see in access to transplant and also to the development of kidney disease. As I mentioned, the chronic conditions that diabetes, hypertension, obesity, and why we see differences. For example, for kidney failure, the rate of kidney failure is 4 times higher among Black or African American patients compared to white patients. And this model, we know that this is really around the inequitable distribution of these determinants of health. And this plays a role, of course, in many populations, but particularly in kidney disease, and perpetuates health disparities. And so things like housing conditions, neighborhood environment, food insecurity, access to equitable, high-quality care really shapes health of these patients with kidney failure and determines their access to transplant. That plays a big role. So that was really the problem that we were focusing on, and our research team was really getting engaged with. And so I'm going to talk a little bit about what our team has done and some of the research in the area of sort of the data and setting the stage. And this is still an important role today of where we play with the data that's informing some of these problems particularly related to access to transplantation. So this is a figure that really is showing a very simplistic representation of how a patient accesses a transplant and this high-quality care, the best treatment option that's available for them in the health system. So really, it starts with saying the very first step of end-stage renal disease or end-stage kidney disease, so someone with chronic kidney disease. In the U.S., a lot of people don't know they have chronic kidney disease if they don't have, I think almost 30% will show up in the emergency room with a diagnosis of kidney failure because if they don't have access to care beforehand. So this is sometimes this reflection of chronic kidney disease and unknowing whether they have kidney failure. We also see substantial inequities in that late-stage chronic kidney disease. But having access to nephrology care early before someone has a diagnosis of kidney failure is really important for this patient population. It just doesn't happen. We also don't have great data on this. And so the stars are representing where we have good data and where we have, that's in the gray stars. It's really well recorded in national surveillance data. The green is you can get some measures somewhere. So CDC has some measures of chronic kidney disease, but we don't have a national surveillance system. So we really don't know what proportion of patients may have chronic kidney disease or late-stage chronic kidney disease, unless you have that measure of their estimated glomerular filtration rate, for example. So we don't have good data on that early access to care. We don't have, one of the key steps is typically most patients, over 90% of patients who do have a diagnosis of kidney failure will start on dialysis. There is such a thing as preemptive kidney transplantation, where they get a transplant before they ever start dialysis, but that is much more rare for some of the reasons I talked about. But typically they're starting in a dialysis facility, and they have to be typically educated about what is a transplant. Then they're referred for transplant. They start a transplant evaluation at a transplant center. So we're bridging two different health systems, and the data from those two different health systems, we don't really have good data on that. Completion of that evaluation is critical in order to get put on the national waiting list. We have a national waiting list for receipt of a deceased donor transplant. Or someone can get a living donor transplant, but they still have to be listed in order to get a living donor transplant. So have a friend or a relative donate a kidney. And then receipt of a transplant. So we have excellent data on those, what's in the gray stars, no surveillance data whatsoever in the orange. And so this was one of the problems that we realized very early on, is that we had the crosstalk of two different health systems. Patients were being dropped in the process. We had no idea. Was the reason why in the Southeast we had the lowest rates of transplant, was it because we had low referral, that these patients just weren't being referred by either their primary care provider or more typically their nephrologist at a dialysis facility? Or was it because they were, after referral, they just, there was no start of the evaluation, so they didn't come to the transplant center? There was some early evidence we had that there was some patients would be referred but never start that evaluation process. Or there are a number of different medical, psychosocial appointments that a patient has to go through. So that closure of the completion of that process is what you need in order to be determined if you're medically and psychosocially eligible for a transplant. And there's a lot of potential bias in that process, I would say, in the evaluation completion, the determination of candidacy. So long story short, we didn't have enough data. And typically, how everyone considered the problem of access to transplant historically forever has always been looking at among those patients who are already on the waiting list and then getting a transplant. And we have really challenged this in the last 20 years, really saying we need a population health approach to look at access to transplant, and we can't start at the denominator of those who are on the waiting list. We have to look upstream as far back, ideally, as someone who has chronic kidney disease. So one of the areas, though, that was we felt was at least the low-hanging fruit were those in orange, when a patient's referred, when they start the evaluation, and when they complete the evaluation. So that began what we have coined the Early Steps to Transplant Access Registry, which is a collaborative project that really sought to measure those steps in the transplant process across the two health systems where we didn't have that data. And then, again, we do have national surveillance system data for some of those steps, but we don't, for the later steps, we didn't have it for those early steps. So this started with collecting data in Georgia from 3 different transplant centers. Transplant centers typically compete for patients. They do not want to share their referral data. And so this was definitely a bit of a shift to consider sharing of data. Starting in Georgia, though, where we had the lowest rates of transplant of all 50 states, was really the motivator of bringing the community together. I'll talk about that in a moment. But we were able to show for the first time that the rates of referral were very low. So given that this is the best treatment option for patients with kidney failure, we only saw that about 24% of incident patients, so new patients with a diagnosis of kidney failure within 1 year, were referred for transplant within 1 year, and that there were a number of dialysis facilities, so what's shown along the x-axis are the 308 dialysis facilities. There were 15 facilities that had 0 referrals over that time period. And that ranged from 0 to 75%, so just an incredible amount of variability. So what has been expanding since we collected that data in Georgia was we did that in Georgia, North Carolina, South Carolina. That was our 3-state network called Network 6. These are the various, there are 18 different end-stage renal disease networks across the country. And we have expanded that in last year. We have 32 transplant centers that have submitted data out of the 48 transplant centers that exist in the 4 network regions listed here, networks 1, 2, 6, and 9. So we don't have national data collection on this yet, but this is something that I'll talk about in a moment too, about policy and advocacy, that this is something that has created, this data collection has shown, I think, the national community that there's a need for this data to collect nationally. This is just a schematic really showing the how we're collecting this data. We link it with, we have a data coordinating center, a quality group that we work with, data coordinating center to share that data. And then we link it with a number of different data sets. And then we're able to create different dashboards for our transplant center partners, our dialysis facility partners, and a publicly available dashboard. And then we have a research data set called eSTAR that we use for research purposes. So some of the things that we've been able to do with these data are showing at different steps in the transplant process, what is the variation at the health system level? And this is a really classic health services research question, I would say, is looking at the variation at the health system level in these measures of access to care. So it's a process measure. It's not the outcome of transplant, but we're going earlier in the step and saying, okay, we see incredible amount of variation in referral for transplant. That's what's shown in orange. And then in the proportion of patients who are evaluated, they start that medical evaluation to determine their candidacy for transplant is shown in blue. So we see a drop off and we see a ton of variability there, which is helpful for us to look at the data and say, where do we see best practices in some of those high-performing dialysis facilities? Where do we see, why are we seeing some dialysis facilities that have 0% referral or 0% of their patients are being evaluated? And that leads to interventions, as I'll talk about in a moment. So this is the team that is responsible for our public dashboard. We have a beta version that we have out there on, I've got the link here if anyone's interested in that, but these are the top 2 are Regenstrief employees that came from our research team at Emory and are now here and started a few months ago, Jade Mongyu, and then Kelsey Drury is a faculty member, health economist and health services researcher. And they have all worked on some of the dashboards that have been helping to inform our partners of where they are. And this is really the first time that the centers and the dialysis facilities can look at where they are in the process. They did not have this data beforehand, and then they're able to use that for their own quality improvement. So now I'm going to talk a little bit about some of how we've then used some of that data in epidemiologic studies, and I'll talk about how some of this data has also informed interventions. So I'll provide a few different examples of some of the data. So the eSTAR data is our quantitative data collection. We have a number of different studies that we have done as well in terms of both quantitative and qualitative data collection. Structured interviews. We always start with a needs assessment of our community before we do an intervention. We've done a number of different needs assessments in Network 6, Georgia, North Carolina, South Carolina. This is something we're also going to be planning to do now that we're moving here and have some of our research that we're continuing in this area. But things like surveys, and so this was at the health system level, looking at what are some of the barriers to transplant at the health system level, and then what are some of the potential opportunities that we can intervene on. So some of the things that we've identified, for example, for opportunities that transplant staff and dialysis staff across these health systems, things like transportation. This is the staff saying what they think are the patient perceived barriers. Transportation always shows up, low health literacy, lack of understanding about the process, low socioeconomic status. Some of those things we can see are clearly social risk factors, and I think one of the newer interventions that I'll talk about at the very end is how can we work with the health systems to address some of these barriers and actually address some of the structural issues at the center level or the health system level to help patients in not just being aware of the social risk factors that patients have, but being able to intervene and help these patients. So this is another example of, I would say, how we're able to use some of the data in a quantitative way that helps inform interventions. And so that's part of the theme I'm trying to communicate, is really the data and the description of the problem is really critical to inform interventions, but we need to do more than just report that there are these disparities. This is one example where we were able to show the dialysis facility level racial disparities in waitlisting. So that kind of the fourth step, I think, in the transplant process that I showed you in that flow diagram. But this shows in blue facilities that didn't have a racial disparity in waitlisting. In this, we were particularly focused on Black versus white racial disparity because of the problems in the Southeast, where the almost 74% of our kidney disease population was Black or African American. And then shows the in red where there are racial disparities in listing. But you can see throughout the entire country that there are facilities that have racial disparities in waitlisting. This data actually informed the selection. We were doing a large quality improvement project. I'll talk about it in a little bit too. But it informed the dialysis facilities in which we selected for an intervention. And so using that data to identify where to target our interventions was important in this context. This is, again, Dr. Drury, some of her work, and again, another example of an epidemiologic study looking at that early referral. So preemptive is referred before you ever start dialysis. And I think this is one of those signals that we see that upstream, if you go further upstream, we see more substantial racial disparities in who's getting referred the earliest. And so that timing of where we're seeing disparities, that provides us with some opportunity for future focused interventions. This is some of her recent work, so will, I think, definitely inform some of our intervention efforts. And another example by Jade Buford, our Regenstrief epidemiologist on our team, that recently showed with some of the data that we have nationally. Not just, we don't have national data on referral or evaluation, but we do on waitlisting. So showing that there are differences in the cumulative incidence of waitlisting. If you look overall, you may find one thing, but if you stratify by age group, you might see something else. And I think that's another core kind of tenet of an epidemiologic study is stratification and effect modification. So looking at the data in different ways. So looking at overall racial disparities is one thing, but if you say and conclude, oh, there are no racial disparities here, but then you look at by age group or by gender, and you see that there are significant disparities in some groups, your overall average might not be telling you the accurate truth there. So I think it's the importance of stratification. And this is one really good example of that, where actually the starkest racial disparities that we see in access to the waiting list are actually among the youngest patients. And those are really those that stand to benefit the most from a transplant and have a longer life expectancy if they get that transplant earlier. And so I think that that's really informative of, or able to inform us of interventions. And so now I'm going to talk a little bit about some example interventions just to give a flavor of some of the things that we've done in the past. And then I'll talk a little bit about a new R01 grant that we had that just started in last month, some of the plans around that intervention as well. So like I said, I'm an epidemiologist by training, love the data, love doing these epidemiologic studies and being able to work with the data and stratify across different groups so we can understand where these problems are, but also never wanted to stop at just describing it, and it wanted to see how could that inform interventions. And so I want to talk a little bit about some of the work that we've done for the last almost 15 or so years that have focused more on the intervention side. And this really couldn't be done without the work of what's called the Southeastern Kidney Transplant Coalition. We now have a larger collaborative that we've set up, especially with our move out of the Southeast, for a community advisory board that's similar to this, but is more on the eStar database and focusing on nationally how do we move some of what we've done in the Southeast beyond. But I think at the time it really started with some needs assessment after we had understood some of the data that Georgia had the lowest rates of transplant in the nation. The Southeast, Georgia, North Carolina, and South Carolina, that network that's shown here, had of the 18 networks across the country, they had the lowest rates in the entire nation. and despite having the highest burden of kidney disease. So this group, collaborative partnership in the kidney disease community, consisted of all these partners that are shown at the right, maybe a little hard to read all of them, but they really reflect patients, patient advocacy organizations, patients' family members, quality organizations that work in this space. They represented all of the transplant centers in this 3-state region, large and small dialysis organizations, so including the for-profit dialysis facilities, which we've also published a lot of research on as well, that they have less, they historically have had less access to transplant, but they were also partnering with us on this, despite some of, I think, the politics there. And some of the smaller dialysis organizations, as well as researchers and others engaged in the transplant and kidney disease community. So it's really a unique group that is bridging two health systems. There is only sort of, because there's the dialysis facilities and the CKD clinics, and then there's the transplant centers. They're often, just like the data, there are disconnects. Patients are dropping out in that process. And so part of it is there's lack of community connections with the providers who are treating patients upstream and those that are more in the hospital-based system, which is typically where transplant centers are. So this collaboration between partners in the kidney disease community, initially, we meet annually, we've met annually since 2010, but came together really because of this problem of having the lowest rates of transplant in the nation, and decided that our goals were really around improving transplant rates in the Southeast and eliminating health inequities and access to transplant. So I've mentioned the RADIANT study, and so I'm going to talk a little bit about, I won't go into all of these, there's 4 of them. I'm going to talk about the first one just to set the stage of how the community really helped inform some of this. So the RADIANT community study, then there was that was focused in Georgia, and then the RADIANT regional study was focused in Georgia, North Carolina, South Carolina. The expansion actually was these are all funded grants. The expansion grant was actually not an intervention. It was more of the dashboards and expansion of data collection. And then the final one, the health systems intervention that I'll talk about in a moment, that was a new one that we just had funded. So the interventions, all of the interventions we've done, and I'd say that in our coalition, we have had, I believe, 8 different interventions over the last maybe 10 to 12 years, maybe 15 years. Many of them are pragmatic trials, and so they're done at the, we're talking about tens of thousands of patients that are included, and a lot of our, by pragmatic, is everyone familiar with the term pragmatic? Most people, pragmatic. So I see a few kind of question marks. So it's often that a typical clinical trial often engages with the patients directly, and you're collecting data. Maybe it's through surveys, or maybe you're doing blood draws, or there's some direct patient-patient interaction. We, as the researchers in the pragmatic trial, actually, and it's not you're a pragmatic or a clinical trial. It's sort of, there's a spectrum. But in the pragmatic sense, we didn't have this direct interaction with the patients. We interacted with some of the health systems and the providers, and they interacted with the patients, but we didn't obtain direct measurement on the patient level. But because of that, we had the resources to be able to intervene, I think, on a lot more people. And so the use of more real-world data is used to evaluate the pragmatic nature of this intervention. And so it is a little bit more on the interventions are more real-world. There maybe are, you're at the effectiveness side, not the efficacy side of the intervention, if that makes sense. So one of them, the RADIANT community study, early on, this really led to, first we did this needs assessment of the community. We had qualitative and quantitative data collection that helped us inform the problem. I showed you some of the images on where we saw that there were racial disparities in dialysis facilities. We saw that there were low referral rates. So those that had really low referral, it was kind of on the left-hand side of that figure. Those are the ones that we wanted to target for intervention. And the process was, we in the room, in day-long meetings would work and use a lot of quality improvement methods, but we had researchers there, and some had interventions that had been developed or they had worked on that had established efficacy. And we worked on a multi-component and multi-level intervention to try to address this problem. I won't go into all the details of the intervention materials, but because it's multi-component, there were multiple. But the first intervention study that we did was delivered over 12 months and included different quality improvement activities on a month-to-month basis. It included some sharing of best practices, for example, for high-performing facilities to low-performing facilities. And it was intended to target health system leaders, the staff within those dialysis facilities, and patients, and it had a combination of different interventions. I'll point out just one because I think it's important. This was the very old version of our dashboard that we used to before we had moved everything online to interactive dashboards. Was something we actually emailed and then physically mailed to facilities. And then we later, this was like the iteration in 2010, but showing you what's called an audit and feedback report. There's a lot of evidence in many other fields of an audit and feedback report, basically a benchmarking report. So though we hadn't tested this in this setting, in this outcome, we assumed that that had established efficacy. But this was the first time that dialysis facilities, for example, knew what was their referral rate, and did they know how that compared to other dialysis facilities in the region. And it was the first time that they were aware, did their facility have a racial disparity in access to transplant or not? And so that was detailed in the dashboard, or in the audit and feedback report, which later became the dashboard. So after 134 dialysis facilities were randomized to receive either the standard care, usual transplant education, or this multi-component intervention. And we looked at the change in facility level referral for transplant from baseline to 12 months and found that in the intervention group that's shown in the darker blue, I think that part of that got cut off, but the lighter blue is the control, darker blue is intervention, nearly doubled. And I think the other important thing was, it was hard. I remember as a researcher and trying to plan this intervention and finding models of what other studies were out there that looked at co-primary outcomes of increased access to care and reduced disparities. So I was struggling, I remember, with how do I even do this power calculation for this? And can I find other examples of this? And I really struggled to find anything in the literature back when we were doing this. This was published in 2017, but we were planning this trial back in 2010, 2011. Of examples that had those co-primary outcomes. And that was, I think, the important, so the design of this, I think, was more novel, at least in the kidney disease field. It was a lot harder to find these types of interventions that were focused on both. But this was one example where we specifically designed the intervention. We had targeted, I think I don't have the figure in here, but who the facilities were that we targeted, the 134 dialysis facilities. They were facilities that either had that low referral rate or they had racial disparities in referral. So that was why we were so interested in that outcome. So after 12 months, we found that the intervention actually reduced racial disparities in referral, and it overall increased referral, so for all the groups. So again, this is the importance, I think, of looking at it in stratified analysis. So we didn't want to look at just the overall, did we increase referral? We wanted to look at it, did we reduce racial disparities? So, we did a number of different studies after this that helped inform the future iterations of this. And I want to just put a plug in for the process evaluation, or the what we do to examine, did this work the way it intended to? And we found high fidelity to the intervention in the majority of our dialysis facilities. What we were able to do, and this is listing all the different interventions that were done over that 12-month period, was consider what actually worked, and using implementation science methods, trying to conduct this process evaluation helped us to identify what worked and what didn't work in more of this real world setting. And really the purpose here was, how do we take what did work and adapt it into the next iteration of the study? So I'm showing some of the team members here we had an implementation science expert, Dr. Kam Escafri, and then some of our students and trainees that were involved in this, and did the qualitative and quantitative analysis to assess this. So looking at, for example, high implementers of the intervention and comparing them to low implementers, and doing interviews and trying to understand barriers to implementation helped with the future iterations of that study, the regional study, for example, and some of our other interventions. And I want to just say, I can't talk about all the different interventions we have, but a lot of these are on the Southeastern Kidney Transplant Coalition website here. I do think that I always am putting in a plug for having more opportunities for funding for dissemination work, making sure that, from the beginning, some of the things that we were talking about in this community coalition around the interventions we were developing and had and were testing were things that were going to be sustainable in practice. And I think that's a really critical component, is that we didn't want to take the funding we had and come in and use that funding for the interventions and then leave the communities afterwards knowing that the money wasn't going to be there to sustain that intervention. I've done one of those studies before. It's really hard when you find something worked great, like a navigator in a transplant center that helped with social needs. It worked great. And then the transplant center said, well, that was too expensive, so we're not going to sustain it. Glad you got the funding to do that for 3 years, but we're not going to continue it. Even though you said it was effective and it reduced disparities and improved access, it costs money, we're not going to do it. So I think that that's where making sure from the beginning you have that partnership and that they can continue it is really important. And so I'm frequently approached by various groups saying like, oh, I've heard you've done this. Like, how did you do this? Are your intervention materials available? And everything that we did was always available. Here, yes, we'll share our resources. This is how you can reproduce this, and trying to provide that advice so that others could implement that, I think, is a critically important way to spread what might have worked in one place and then adapting that in context so that that can be done elsewhere. So these are some examples of some of the things that are highlighted on our website for some of the various trials and pragmatic trials and studies that the Southeastern Kidney Transplant Coalition and some of our research team has done. And I'm going to just say one more thing on the interventions, which is a note that I mentioned on our most recent R01. And this is going to be done at 4 different transplant centers. And it is going to start with a needs assessment more on the health system level. And one of the things that we're really focused on for this, the Radiant Health Systems, HS stands for health systems, is targeting some of the structures in the health systems and trying to change them. So we're trying to assess right now the culture and willingness to change some of these structures in the health system. I'm going to give a few examples of one that actually our coalition has targeted in the past with success, but we don't have great data on what was the actual impact. But it was the requirement of all the transplant centers. This was probably 5 years ago or 6 years ago. Every transplant center had this, in our network, had the requirement that you had to have a dental exam every 6 months. So that dental exam every 6 months is for preventing infection, which can be really complicated for a patient to get on the list and to get a transplant. And so they had this requirement. But we were able to show that there are, because we had seen racial disparities in access to that particular step that requires this transplant dental exam, that this was actually a hindrance to one particular patient population. Those that have higher social needs impacted our minority patients, and those who had lower socioeconomic status more and differentially than those that didn't. And so we, through the really advocacy in our coalition, were able to remove that as a barrier so that the transplant centers don't have that anymore. And I think that has helped. But this is this health systems intervention. We're targeting policies like this. We don't yet have the interventions identified, but we have different candidates, and there are things like that. So what are some of the structures at the health systems that are differentially impacting different groups of patients? So another one is parking costs for patients, and does certain health systems charge for parking, and is that a particular barrier? Another one that we're targeting is there's a policy, I know at least a few transplant centers have a policy where if you don't get a call back, so you've scheduled and you've been referred, they're trying to call you to schedule an evaluation, and if they don't hear from you after 3 phone calls, they close out your application, they close out your referral, and assume you're just not interested, or they're closing out the process. So it's taken a lot of education at the health system level to say, well, some people have different work schedules, or are you calling them at the same time every day? Have you tried in your process to allow for evening phone calls or weekend phone calls in addition, so that you're not closing it out by calling people, and then some people, their phone number changes, or their address changes, it's harder to get a hold of them. Are there other things we can do instead of having this policy of closing them out? There's another policy example at the health system level where there are some transplant programs that require patients to fundraise in order to get even put on the waiting list. Private hospitals, they can do that. It's not illegal. It sounds a little bit crazy, but the transplant programs, I know one had a policy of the patient had to raise $10,000, and this was in part to cover the cost of the immunosuppression medications that they would need to cover post-transplant. But of course, we can see that that is a pretty big barrier for some patients, and that can actually result in racial disparities. That is an example of structural racism. So these are some examples where in this intervention, we're going and we're starting with some discussion, some health system interviews with some health system leaders, talking about what are some of the existing structures that might be in place at some of these health systems, and what is their willingness to change some of those policies. And so we will have, in the first year or two, this really intervention development, kind of organizational readiness assessments, and then working with a larger group and a community advisory board on the pilot testing and then implementation of that intervention. So now I want to talk at the last part of some of the last area where I'll say I'm giving some examples of some of the work that our research team does, and this is on the policy side of the equation. And I always say, I think that the policy change is one of those, one of the biggest determinants of health that we have, and it's the biggest, it has the biggest impact on the population. So we can do all this intervention work and spend a lot of time and money where a policy change can fix things, and even the smallest change can have a big impact because it's on the population level and it's affecting everyone. So it's something that I think we are, on our research team, are really, we find this a really important component of the work that we do in advocating. So it's policy and advocacy to, on the problems of improving access and equity to transplant. So I'll give it just a few different examples of studies we've done, and then provide a few examples of some of the things that we have actively going on as well in this area. So I mentioned our Southeastern Kidney Transplant Coalition had worked together on a number of interventions in the Southeast, as well as nationally. And some of those interventions and some of the epidemiologic work we had done showing that there were inequities, we did a lot of advocacy. Now it's been a number of years, so the 2014, there was a major national policy change in how kidneys are allocated to individuals. And so one of the things we did was evaluate. This study is looking at the evaluation of that change in the kidney allocation system. But the advocacy part of this, even before the allocation system was changed, was this change would have a profound impact on racial disparities in access to transplant. And so this was something we really advocated for and pushed for. The policy before 2014 was that you had patients, when they were diagnosed with kidney disease, again, they still had to be referred and evaluated and listed to get on the transplant waiting list. But in 2014, they changed it so that the start of dialysis, it was backdated. And so though it still took time, you still had to get on the waiting list, your time waiting was counted from the date of dialysis start or diagnosis, not from the first time you were listed. So again, that's a structural barrier. I would say that's a major structural barrier at the macro social level, that if you change that, that has substantial impact on disparities, because we knew that that was part of the, because of delays in access to care, we saw substantial racial disparities because of this policy. So this is something we were actually able to show in the data using some of our national data, that once that policy was implemented, at least among those that were already on the list, racial disparities were eliminated in access to transplant. Now, that is with access to deceased donor transplant. There are still substantial disparities in living donor transplant. And as I mentioned before in the talk, there are still substantial disparities in even getting on the waiting list, so and even getting referred. But that's just an example of some of the work that we've done on the policy side. The other is in quality metrics. So this is I really like talking about the area of quality metrics as it's a lever, a policy lever. It's a really a macro-social policy change too that can also have a big impact on the health system. There are also lots of unintended consequences with health quality metrics, but this is one where we've done a lot in suggesting. I've done a lot of advocacy and co-chairing a lot of these different, co-chaired a few different of these CMS groups, recommending different measures for changes in quality metrics, because right now the two health systems in this field are not well aligned, and they're not really patient oriented. This was one that led to a policy change. It wasn't perfect. There's still some problems, but this was some work by a partner co-investigator, Dr. Sudeshna Paul, who's in our School of Nursing at Emory that we worked with as a co-investigator, who had done some work on standardized transplant ratios that was recommended to CMS as a quality measure. It is unfortunately not in place yet, because the main thing that they said was, we love this, but there's still not national data on transplant referral. So that's where we have this data at the 32 transplant centers, and I'll talk about it in a moment. That is also where we're advocating on the policy level, and this is finally in. It's a component of one of the a big bill that was just passed by the Senate and the House related to changing how the transplant ecosystem is organized. And I'm still in constant conversation right now about collecting some of this data on referral nationally to inform some of these quality metrics. So I think that is, again, it's one of those things that if you change even just this one thing, could have a substantial impact. We're also advocating for this. This is Dr. Katie Ross Driscoll is a new faculty that came from Emory as well, epidemiologist by training, and is in the Department of Surgery here at IU, and a Regenstrief investigator in HSR. And she's looking at this as well on in our Scientific Registry of Transplant Recipients, which does the quality metrics and sends reports to centers nationally. Some of her work in this area, defining the appropriate denominator that's not based just on those who are on the waiting list, but is based on a population-based denominator that she created some of these methods for, are being considered by the Scientific Registry of Transplant Recipients for how can they use that in some of their reports. And this is an example of I was just on the Hill this spring. This was actually with Nupur Gupta, is a nephrologist here at IU, who's also on our American Society of Nephrology Advocacy and Policy Committee. But one of the things we were doing this spring was trying to advocate for this, securing the U.S. Procurement and Transplantation Network Act. That's what I was mentioning, is it's a reorganization in some ways. And one of the key recommendations is, among a number of things, but the thing that I kept talking about was my pet project, which is we have to have referral data collection nationally. But it's related to more largely the structure of how transplantation care and data affects the transplant ecosystem and what some of those changes should be. So I think this is a really important step on the policy and advocacy side, and it's something we'll continue to advocate for. Okay, I'm going to spend the last just 4 minutes, and then I want to leave time for questions, talking a little bit about some of the local context and some of the things we're bringing here. And so, one of them is looking at the data that we have in Indiana, and this is a figure that shows those standardized transplant ratios, or the number of observed over expected transplants in the state of Indiana. And the orange line is the expected, so that would be the national average. So on average, you might say, okay, well, 0.97, on average, we're actually in Indiana doing okay with respect to access to transplant if you use this measure. It's not a great measure, but in this one, but you might then look and say, well, actually, if you look at it by dialysis facility, you see there's opportunities for improvement. So there are still dialysis facilities that have no transplants over a 4-year period, and that there are a number of facilities that are performing under expected. And so these are things where it's, okay, well, we need to look more in the data. It's hard to say. There may be a variety of reasons explain that. We can look at this too at the steps prior to transplant. So again, with that data that we have in that E-STAR data collaborative, we only have 4 of the transplant centers in network 9 submitting data. So that's one of our next steps, is trying to get more transplant centers to submit data in this region. But of the data that we do have for referral and evaluation, and both Jade and Mong Yu have done a lot of work in this area, and our dashboards related to this. We see substantial variation in referral and evaluation start in Indiana, Ohio, and Kentucky. And this is all available on our dashboard, the publicly available dashboard, but you can look at things like referral over 1 year and changes over time. And these are some of the things we're using this data to look at descriptions of what's going on in one network or this network compared to other networks. I'll maybe just pause on one or two of the data components from the dashboard as an example. But this is showing of the 4 transplant centers that we do have data, we see differences in the proportion of patients who start the evaluation at the transplant center within 6 months of being referred. So one transplant center has 66% of their patients start the eval, another center has 48%. And then we can see that there's differences actually across the network. So the different groups here are Network 1, that's New England. To the right, that's Network 2, that's New York. And then the third one on the left, bottom left, that's Network 6, and that is Georgia, North Carolina, South Carolina, and Network 9. So the bottom right-hand corner is our region here. Of Indiana, Ohio, Kentucky. But we can see, for example, that there's different proportions of patients starting the eval across racial groups. So again, these are crude data. We have these are helping us to inform that there are differences by race across region, and trying to look at now this will inform our epidemiologic analyses where we will look at geographic differences and so on. Kathy, I'll just real quick mention Kathy Kelty, who I asked her to send me a couple slides on her most recent work that she's doing with some of the IU and Eskenazi group. Mung Yu and Jade are also working on this team, and some of our other, both IU and Eskenazi teams are involved in this. But looking at, we're starting to examine some of the data. Eskenazi Health has identified that they believe there's a disparity in access to transplant and I think that some of the IU Health transplant team may be, that there are some inequities in the process. And so we're looking at some of this. This is, again, all descriptive for now, but Kathy's starting to look at this, or Dr. Kelty is starting to look at this in a patient population of about 12,000 patients from 2016 to 2020. I'm just going to highlight real quick a few things there. So this is looking at the steps in the transplant process. So among patients, the patients who had a referral within 1 year, among those that were referred in the middle column, what proportion had an evaluation within 6 months, and then at the last one is what proportion were waitlisted within 6 months. And I'll just highlight a couple of different things that, again, these are crude. We haven't run any modeling. There's no adjustments here, so this could certainly change, but it's the first step with describing the data and understanding it. But there are some signals here that if you go across these transplant steps, both gender and race, that we see differences in the drop-off. Maybe I'll just highlight this for now. So we got 68% of the population of white patients referred within, what percent had a referral within 1 year, and 24% non-Hispanic Black. When you go over to among the referred patients, what proportion had an evaluation? In theory, this should be about the same as the prior step, but we see 69.8%, 19.5%, and then in the last column for waitlisting, 73% of whites, but only 13.9% of Black or African American patients, non-Hispanic, that were waitlisted within 6 months. So I think this is the signal and things that we are going to be doing doing needs assessment, and would certainly do that and look at the data before we do any kind of interventions. So, some of the conclusions and next steps for this, I think continuing to collect data from transplant hospitals, expanding in our network, using the data to inform where to target interventions, and doing that needs assessment locally are really where we're hoping to do some of our work here in this region. So I'm going to stop and hope we've got 8 minutes for questions, but want to thank and acknowledge our team, our research team here, our Southeastern Kidney Transplant Coalition, and our various collaborators and funding support. And thanks to all of you for listening. Hopefully this is a helpful context to some of the research that we have going on in our research team. So I'll take any questions. Not everyone at once. Yes, Sean.
Great work, of course. I'm on. So you mentioned a couple of anecdotes, I think, on some of the factors. You mentioned the $10,000 fundraising issue. You mentioned the time on dialysis issue. What are I'm trying to understand how your interventions addressed which issues. So, and I'm not sure what all the issues are, so I'd be curious to just
It's
hear.
great. I flew through a lot, and I kind of set this up as lots of different examples to give a highlight of everything. So it's harder to tell. So I'll give one example of an intervention that we did that worked. So one of the things that we did when that policy changed, that I mentioned with the time on dialysis, we conducted this intervention that was national. We targeted dialysis facilities that had low wait listing nationally, and we had a quality improvement and education intervention that we delivered to the health systems, the dialysis facilities, to inform them of the policy change. So because we had some data that had shown that actually a lot of dialysis facilities had no idea the policy had changed. So that's one example of, all right, policy changed, nobody even knows that it changed, especially because the transplant centers were aware of that change, but the referring providers weren't aware. So we delivered an intervention that really showed them, hey, the policy changed, but also said this could affect this proportion of your population. If you were to refer these patients, this could increase, access. So that was one example. Some of the radiant work that we targeted, I don't think that, so how I presented the talk today was lots of different examples and thematic issues. I think a lot of the ones that that I mentioned at the end, those at the health system targets, those are the ones that we're targeting in a new intervention that we haven't even started. The only one that we had targeted in the past through a multi-component intervention was that dental exam that I mentioned. I think that part of it is a lot of the examples that I gave. So Radiant had targeted the dialysis facilities. Right now, this one that we're talking about with a lot of these policies for fundraising or the dental exam, that's actually at the transplant center level. And so I think that it depends on which health system we're talking about. But I think that there are so many options to choose from. And I think that the opportunities are, I think it's just going to be which one do we choose, or is it multiple? And that's one of the other things that I think we've struggled with from the researcher side. It's, I wanted to say, well, let's pick one intervention or one thing we're targeting, because then we know exactly whether it worked or not. But it's been a bit of a push and a pull there, because we work with the community partners and they want to fix it all. Like if there's a problem, we're not going to just do this research study where we're focusing on your one thing. So I think that's just been part of the challenge of the research side and the actual implementation, and that some of those things have to happen together. So the Radiant example is a good one, where it was a multi-component intervention where we targeted, it was like the dental exam was one thing, but we also did audit and feedback reports where we're just the intervention alone of telling you that you have a racial disparity, and using that as an intervention combined with all the educational components of telling health system leaders or saying, hey, you need to do a root cause analysis and distribute this material to your facility staff on who they should be referring for transplant. We can't really tell exactly which intervention worked. That's, I think, the importance of the process evaluation and assessment of the fidelity of the intervention, that we were only able to get to some of that as more on the side of did they actually use the intervention or not. So we had 10 different things they could do, but they didn't do all of them. And so I think it's a combination of it may be important and it may have efficacy if you test that one thing, but if people aren't actually going to use it, it won't. So I don't know if that quite answers your question, other than it's complicated and there are endless opportunities for intervention. Other questions?
We have a question from the online
Great.
Community. I noticed that you have previously worked with surgeons in this work and in your prior position. What challenges did you encounter, and how can you engage surgeons here at IU?
Okay, great. Yes, we have worked with a lot of surgeons. Surgeons were part of our Southeastern Kidney Transplant Coalition. I think we're already working, and some of our junior faculty are working with the surgical group here at IU that are part of CHSR. And I think that, I've been in a lot of conversation with the IU transplant team, for example, and the surgeons there. Jonathan Friedel, who's the transplant division chief, is pictured here in this, and he's in the back row over there. So I think that's the important context of, we wouldn't want to just come in here and say, oh, we've done some of these interventions in the Southeast, let's do them here. I think the context has got to be, we need to understand what the problems are. Is there a need for any intervention? So it's been starting with, let's talk with some of the transplant surgeons and the Eskenazi physicians that I mentioned who are saying that there's a problem. But first, understanding in the data, and then talking to the key stakeholders. So that's the surgeons, the nephrologists, the social workers, the transplant teams, as well as the patients and their family members and others in the community who are caring for these patients. So, but certainly lots of opportunities to collaborate with the surgical team on that. Thank you for the question. All right. Any other last questions? Great. Okay. Thanks so much.